So we can largely classify antidiabetic drugs as listed. So we have insulin. So this can be channeled toward the diabetics. And we have the oral hypoglycemic agents, even though we'll have a complete classification of the oral hypoglycemic agents. So example of oral hypoglycemic agents include A-sulfonylureas, where it can be further subdivided into first and second generation. We also have biguanides, meglitinides, dalazolidinediones, alpha-glucosidase inhibitors, and we also have glucagon-like peptide, and also sodium glucose cotransporter. And I think that which is not in the list, dipeptidase inhibitors, where we normally have the sitagliptin and the vidagliptin. So if you are able to see in the classification, our number one drug will be the insulin. So insulin can also be subdivided, as you can be able to see, based on their duration, how soon they are likely to work, and how long they are likely to work in the body. So we can have rapid active soluble, short acting soluble, intermediate acting lente, and long acting referred to as the ultra lente. So they have they just have similar attribute to the normal endogenous insulin that we just discussed. So what is insulin? Insulin now as a drug. So this is a polypeptide hormone of a complex structure that normally plays a significant role in the regulation of carbohydrates, fat, and protein metabolism. So you are able to see that their use was beyond glucose or carbohydrate metabolism, in that it can also influence fat and protein. Diabetes mellitus normally results from either insulin deficiency in terms of synthesis or secretion, or of course resistance. But in the insulin as a drug, will ordinarily use it in those who have insulin deficiency. Insulin is inactivated by the GIT enzyme, and it is for this reason that it must be given by injection. The subcutaneous route is usually ideally in most cases, but insulin can also be given in IV or in IM. It is normally injected on the upper arms, thighs, buttocks, abdomens, and there may be increased absorption from the limb site if the limb is used in strenuous exercise. So these are some of the things that are likely to increase the local absorption of the insulin. So let's just remember this. Insulin as a drug, generally in terms of its pharmacokinetics, insulin naturally secreted by the pancreas, it's likely to enter the portal vein and passes the liver, which takes up to around 60%, and the rest enters into the systemic circulation. So we'll only have the 40% into the systemic circulation, where its concentration will be less than 15%. Insulin injected subcutaneously enter the systemic circulation, and both the liver and the peripheral organs receive the same concentration. So you remember the blood vessel from the pancreas. Once we've had our hormone from the pancreas, they'll definitely get through the portal system. So this is unlike the exogenous insulin that can be given parenterally. So somehow, at least it can be able to bypass that initially. So insulin is distributed only extracellularly. Insulin injected or released by the pancreas is metabolized in the liver to a small extent in the muscle and also kidney. Nearly 50% of the insulin entering the portal vein from the pancreas is inactivated in the first passage through the liver. During the biotransformation, what is broken down is normally the disulfide bonds, and the A and the B chains are separated. You remember the structure of the insulin. So the specific chains might be further broken down into specific amino acids that normally partakes in the formation of the specific chains. So what is the mechanism of action of insulin? By now we know this because we covered this in our introduction part, so you can just revisit that. So what are some of the clinical indication of the insulin? So insulin can be used in the diabetes mellitus, mostly type 1. Insulin will be preferred in the diabetic ketoacidosis, DKA, where at least with the insulin you are not likely to subject your patient to more acidosis. That can be a major side effect with the oral hypoglycemic agent. It is indicated for the gestational diabetic mellitus, malnutrition-related DM, diagnosis of the growth hormone deficiency, anorexia nervosa. This is because insulin is likely to improve appetite. Primary or secondary failure to oral hypoglycemic, and when surgery is needed. So these are some of the indication of insulin. And when we are talking of maybe when surgery is needed, these people need, of course, they need to be diabetic. So not everybody that is just supposed to go to through surgery. But if you are diabetic and you are supposed to go to surgery, we'll prefer to give insulin rather than the other drugs. This is because of the anticipated acute complication that can occur post-surgery. So if you give your insulin, the patient will be well placed. So almost related, what are the uses of insulin? So in diabetes mellitus, the purpose of insulin is normally to restore the metabolism to normal. And of course, while doing that, you want to avoid the symptoms due to hyperglycemia and glycosuria. Prevent short-term complications such as infections, ketoacidosis, and also your aim is also to prevent the long-term complication that might revolve around the cardiovascular, retinal, neurological, and renal system. Insulin is needed when the diabetes mellitus is not controlled by the diet and exercise, or when these are not applicable. There are some people who might not be able to partake in the exercise, so you just give them insulin from the word go. Insulin is needed when there is a primary or secondary failure of the oral hypoglycemic agents. So when oral drugs cannot be tolerated, you'll definitely want to give insulin. Insulin is given in underweight patient. It can be used temporarily to tide over infections, trauma, surgery, pregnancy, any complication of the diabetes mellitus such as ketoacidosis or gangrene. You'll prefer insulin. So most of the time you could find that in some of these states such as ketoacidosis, those who are having infection, trauma, supposed to go to surgery, could be dealing with the type 2 diabetes. But when these circumstances comes, you'll rather transition from the oral hypoglycemic agents into insulin. So what are the precautions that you need to take while administering insulin? You need to monitor the signs of hypoglycemia. If there's a renal failure, you need to reduce the dose, and also caution with the beta blockers. Remember the effect of the sympathetic stimulation on the liver, what that can do to the in regard to the blood sugar. So those who do not tolerate the insulin, also be cautious. The drug interaction. Drugs that can interact with insulin, corticosteroid antagonizes the effect of the insulin. These stimulating the release of catecholamines, which causes the hyperglycemia. So remember, things like cortisol are normally considered as mobilizing hormones. Thyroid hormones, it's likely to increase the insulin requirement, because with the thyroid, there is a lot of metabolic processes. So the metabolic process of the body is somewhat increased. And of course, when the metabolism is high, you need to give an equal amount of oxygen and energy. So we actually require a lot of glucose. Androgens increases the tissue sensitivity to insulin. Large amount of alcohol, this enhances hypoglycemic effect of insulin, because we know that alcohol in itself, once taken in large quantity, it can trigger hypoglycemia. NSAID increases the basal insulin secretion. Quinine reduces degradation of the insulin. Potassium wasting diuretics will inhibit secretion of insulin and reduce the sensitivity to insulin. So in the interaction, you should be aware of some drugs that can be able to cause hyperglycemia, while those that are able to cause the hypoglycemia, you should also be aware of this. This is because maybe you are monitoring a diabetic patient. They are on a standard dose of an insulin. So when the time comes and maybe they need to take these other drugs, you need to know how, if you are supposed to reduce the dose, or if you are supposed to increase the dose, or if at all you need to avoid the drugs. So for example, we have the drugs that can increase the level of the sugar. So this include the calcium channel blockers, the growth hormone, the epinephrine, the oral contraceptive, glucagon, heparin, nicotine, and phenytoin. We have those that can reduce the blood sugar level, and this might actually increase the toxic effect of insulin. This is because insulin can also cause the hypoglycemia. These agents include ACE inhibitors, bromocriptine, ketoconazole, mebendazole, pyridoxine, diauphylline, and sulfonamide. So you should be aware of this. Of course, the major contraindication for insulin will be hypoglycemia. If you are hypoglycemic, we don't want to give you insulin, especially at that particular moment where you are hypoglycemic, or any other condition that could be having some tendency of hypoglycemia. So what are the adverse effects? The same, hypoglycemia. This is something that you want to avoid. And in the process, or maybe as a caution, you should always be having a mechanism of trying to restore the sugar. So maybe through the patient, they can be having these chocolates, or maybe as a facility, you should always have the different concentration of dextrose. So what are some of the things that might aggravate the hypoglycemia? So this can result from delay in taking the meals, inadequate carbohydrates consumption, unusual exercise, and maybe even large doses of insulin. Another adverse effect could be insulin allergy. Those who are hypersensitive to it, even though rare. Immune insulin resistance, edema. This develops short-lived dependent edema due to sodium retention when insulin therapy is first initiated. So these are some of the things that you should be able to monitor. Weight gain can also be there. Remember what insulin normally does. It allows, or rather it normally encourages some fat synthesis, converting a lot of glucose into fat. You also expect some local reaction, having that you are giving some form of injection. So insulin locally can encourage fat formation around that particular place, giving it some fat hypertrophy. So this is what you can refer to as lipodystrophy. So of course there could also be swelling and erythema. So these are due to direct effect of the needle. You also have a phenomenon by the name insulin resistance, in that sometimes insulin can be produced, maybe let's say at an inadequate amount. The amount is adequate, but maybe not functioning well. Or maybe another scenario could be you are having a patient who you are managing for diabetes type 1. So they've been taking a standard stable dose of insulin, but there comes a times when they can be insulin resistance. So this might mean that when the effectiveness of our drug reduces. So there are some circumstances that we can predict and attribute it to resistance. So for us, our business is just to identify these factors that are promoting resistance. Most of these are likely to be temporary factors. Temporary factors meaning that you can be able to direct, maybe if there are diseases, some drugs toward this, and once they are off, the insulin function will be restored to normal. So maybe you'll be able to get rid of these temporary factors, and maybe this is the time that you might also want to temporarily increase the dose of the insulin. So up to a certain time when these temporary factors are no longer in the body, you revert to your normal dose. So let's explore a little bit the insulin resistance. So this is said to occur when the resistance to the effect of insulin on glucose uptake, metabolism, or storage is diminished. There are some causes of insulin resistance, some acute, some chronic. So our much interest is mostly, of course, both are important, but it is good for us to identify these factors or these causes. If we can be able to change them, we change them. Number one, for the acute: infection, trauma, emotional stress, surgery, and corticosteroid. So this is to suggest that if your patient is taking a certain dose of insulin, when exposed to these circumstances, the level of glucose might increase. So if you do not have the right diagnosis in terms of identifying these factors, you might think that your drug maybe is not working, or it is not just working, and you might end up increasing the dose and give this patient a long TCA at the time that they need to come back. So if you give them a longer TCA beyond when these factors or these causes are restored, you can increase the chances of hypoglycemia. But if you are aware of these causes, you'll want maybe to alter the dosage for a period of time when these people are having these infections, trauma, emotional stress. Once these factors are off, you revert to your dose, or maybe again you monitor the RBS. So another factor could be a ketoacidosis. This is marked by ketone bodies, free fatty acids, metabolites. This normally inhibits the glucose uptake by the brain and the muscles, and inhibits insulin binding site. So once the ketoacidosis is restored, the insulin function is likely to be restored. We also have some other causes that can be classified as chronic. So this is seen in patients treated for years with conventional insulin preparation. It results from development of antibodies and is common in type 2 diabetes. So example could be pregnancy. So when somebody becomes pregnant, the insulin resistance kind of chip in. Oral contraceptive, acromegaly, so these are other conditions. Cushing syndrome, pheochromocytoma, lipoatrophic diarrhea, and hypertension. So these are some of the things that might be affecting the way insulin is functioning. So for you to optimize the functioning of the insulin, it will mean controlling these diseases. So having them managed. So if you manage them, it means that you are likely to restore your insulin without necessarily increasing the dose, because your insulin will still work, but you'll need to do that by increasing the dose, maybe greatly. But an alternative way is maybe managing this condition. So if you manage this condition, maybe there will not be a great need for you to increase the dose, because remember that anytime you are increasing the dose, the chances of getting also the hypoglycemia increases significantly. So we have various sources of insulin. I want you to look at this. We have of course, we are dealing with the human insulin, the animal insulin, various sources, whether from the pig, cow. I want you to look into that. Those that are on top of the synthetic are using some DNA, maybe recombinant technology. So after maybe looking into the sources, I want you to maybe appreciate the specific attributes of each. Maybe number one, why will you prefer human insulin over the other animal, synthetic? Which one is more effective? Which one is more affordable? So there are aspects of affordability, efficiency, availability, and of course availability also matters. Which one is more tolerable? in terms of there are some, for example, with the animal-derived insulin, there is an increased tendency of having some immune allergic responses. So I'll want you to study the various sources of insulin and appreciate specific attributes in each group. So still on our insulin. So insulin as a drug can be categorized as we categorized early. So we can have the short-acting, rapid-acting, intermediate, long-acting, and the mixture. So when insulin is being prepared, this is normally influenced by three main factors: the strength, the source, and the formulation. So that's why the specific attribute will be very important when examining the sources of insulin. So these can be classified into rapid-acting insulin, which are likely to be soluble. A good example is insulin lispro, insulin aspart. I know we've interacted with this. A short-acting insulin, soluble. So this is regular insulin. Again, we could have interacted with this. We have an intermediate acting. Lente insulin and isofen are example. We have a long-acting, referred to as the ultra lente, and we also have the mixtures. So mixtures, the biphasics, meaning that you are mixing the soluble and the insoluble. So insoluble could be those such as the isofen. So a good example could be mixed for this. And a good example for this regular insulin, I think we have it over there, Actrapid. So as you are moving down the ladder, maybe apart from the mixture, from the rapid to the long, these are expected to act rapidly, while these are expected to have some delay in terms of controlling the sugar. But when it comes to the sustenance of the action, the long, it should be moving like this, where the long is more sustained, can control the sugar for a very long time, followed by intermediate, short, and rapid, so that you have that even though the drug is rapidly acting, it won't be able to control the sugar for long. So this should tell you that this may be, if they should be administered for a very long time, they might require maybe twice or 3 times schedule in terms of drug administration. And it might also tell you that these drugs could also be very important in emergency situation, specifically maybe the first two, where they are rapid and short acting, where there is an urgent need to control the hyperglycemia. For maybe long-term use, you might prefer the long-acting. This is because their dosing schedule can be once a day. So those are some of the things that you'll be considering. So more specifically, these are the types of insulin. So still respecting our class, we are having the rapid, short, intermediate, and the long. And under each, we are able to see the specific examples. Not really the specific example, but these are likely to be soluble, where these are likely to be insoluble. So let's explore the rapid. So for example, you're having a rapid insulin. If you give it, you expect the onset of action to kick in within 5 to 15 minutes at most. So it means that after 15 minutes, the level of the blood sugar should be reducing. And by the time you will be reaching 1 hour, you should be having an optimum glucose control, where it can be maintained for around 3 to 5 hours. It can stretch to 3 to 5 hours. So after 6 hours, you don't expect these drugs to be working. So if the sugar, maybe the sugar will again start to re-emerge, or may start to rise again. So you might be forced to repeat the administration maybe after 5 or 6 hours at most. Why is this important? So this is important for one reason. In an emergency context, maybe the only insulin that you are able to access is the rapid. Of course, after giving the insulin, you should be in a position to assess whether your insulin is working or not. So this is important because we don't want you to be in a state where maybe you've given the rapid insulin and maybe you are buying too much time and maybe taking up to 1 hour or maybe 2 hours to reassess your RBS. So if you take 2 hours to reassess your RBS, it means that you if this drug was to cause hypoglycemia, you can easily miss it because at the back of your mind, you are not anticipating this drug to act early. But if you anticipate it to act early, at least by 15 minutes, you should be able to start to check how the RBS of the patient is faring. So similarly to the short-acting insulin, so whereby this the onset of action can stretch from around 30 minutes on average. So from 15 to 30 minutes. So on average 30 minutes. So what do you do with this information? You don't want to recheck the RBS prematurely. You need to be patient until we are past 30 minutes. So the best could be after 1 hour or 2. If you check it after 15 minutes, you might say that your drug is not working. And if you think your drug is not working because you've just checked the RBS prematurely before 30 minutes, you might end up giving another shot of short-acting insulin. And what now will this mean? It will mean that when your drug will start to act, maybe at 30 minutes, you will now be dealing with hypoglycemia rather than hyperglycemia. So the onset of action in terms of timing, you should be having that approximation and the time where you expect this to peak. So it will peak between 2 to 3 hours and then extend their role to around 5 to 8 hours. Intermediate, we have two, Semilente and Isofen. So Semilente works, the onset is expected to kick in after 1 hour. Isofen also between 1 hour and at most 2 hours. It will peak at 10 hours and this peaks at between 6 to 10 hours. So you are able to see that this might not be good for emergency. This is because you've given the Semilente or this insoluble insulin, and after 1 hour you are still wondering why the RBS is not being controlled. So if this is the only insulin that you are having, you might end up overdosing this patient, giving a high dose of insulin because maybe you are thinking that the drug is not working, only to find that after maybe 10 hours, the patient's going into hypoglycemia. By this time, it could be worse, almost nearing to death. So these are some of the things that you need to take into consideration. While it has peaked between 10 hours, this can persist to up to around 16 hours for the Semilente, and Isofen, it can stretch up to around 28 hours. And we have a long acting that acts between 2 to 4 hours, that is in terms of onset, peaking at around 8 to 12 hours. So the most appropriate time to take the RBS for this, to assess if it has worked or not, is to assess it maybe after 6 to 10 hours for the Semilente, 10 hours for the Isofen, 8 to 12 hours for the Ultralente. So this, the rapid insulin, we suggested that we normally have the insulin Lispro, the insulin Aspart, where the action of this is expected to be between 5 to 15 minutes in onset, peaking at around 1 hour. And this is likely to be sustained for around 3 to 5 hours. So after 3 to 5 hours, don't expect the drug to be still acting. So this is best for diabetes mellitus, of course, and in situations such as diabetic ketoacidosis, because these are circumstances where you want to reduce the blood sugar as soon as possible. Short-acting soluble insulin, example regular insulin. we are able to suggest something like Actrapid. They'll have similar indications, diabetes mellitus, diabetic ketoacidosis. So we are able to see acting between 15 to 30 minutes, where 30 minutes on average, peaking between 2 to 3 hours, and it can last between 5 to 8 hours. So this is available in subcutaneous, can be given through IM and IV, soluble insulin, even though we have a standard of 10 international unit, but we should be having a specific way to calculate the insulin dosage. So this can be available in terms of it can have some pens and also just vial for injection. We have the intermediate. We had two, the lente insulin and the isofen. Isofen is much longer compared to the lente. Lente insulin is a mixture of semi-lente, amorphous zinc suspension, and the ultra-lente, poorly absorbed crystalline Zn or zinc suspension. Lente insulin has rapid absorption with a prolonged duration of action. This is what we are able to suggest. So these drugs can be given once a day or twice. If the dose is over 30 international units per day, it is recommended that you give two-thirds of the amount in the morning, while the other third in the evening. Long-acting. So these, of course, are now the ultra-lente, consisting majorly of the insulin zinc crystalline suspension, protamine Zn suspension, and insulin glargine. So all of these have delay absorption and peak action with the long duration of action. So these are preferred to be given once a day. So these are available in cartridge or by injection device called the pen, which normally holds the insulin in cartridge form with a meter, required dose, and the ordinary needles for injections. Site for injections for these insulins include the upper arms, thighs, buttocks, abdomen, and they may be increased absorption of the insulin if the site is a little bit active. So away from insulin, we also have the oral antidiabetic agents, otherwise known as the hypoglycemic, or some people might call it blood glucose regulators or normalizers, or blood glucose reducing agent, or insulin sensitizers, or anti-hyperglycemic agent. So these are very much commonly used in the diabetic type 2 mellitus. So what are some of the specific indications that these drugs might be used for? So if somebody, of course, is diabetic, they are being diagnosed with diabetes when they are above 40 years of age. So you just give the oral antidiabetic drugs. So this is with major presumption is that you are likely to be dealing with the type 2 diabetes. So if there's obesity at the time of presentation, you'll again want to give the oral antidiabetic drugs. So you'll be able to see some of the specific drugs that might be able to reduce obesity. I know you've come across something like metformin. The duration of the disease is maybe less than 5 years when starting the treatment. Fasting blood sugar was less than 11. Of course, between 7, beyond 7.2 or 7.8 is normally diabetic for the fasting. So between 7.8 to 11.1, you can give somebody allowance to use the oral antidiabetic drug before rushing straight into insulin. You are assuming again these people are having type 2 diabetes. They are above either 30 years or above 40 years. When the insulin requirement for these individuals is around 40 international unit per day. When there is no ketoacidosis or history of it, other complication. So the drug interaction, again, you should be aware of the same drugs that we mentioned. those that can increase the level of glucose and those that can reduce the level of glucose. So increased hypoglycemic effects are likely with the drugs if they are taken together with alcohol, phenylbutazone, chloramphenicol, cotrimazole, sulfonamides, and the trimethoprim. You can also have the decreased hypoglycemic effect if the drugs are taken with rifampicin. This is because for specifically with drugs like sulfonylurea, rifampicin is likely to accelerate their metabolism. Corticosteroid, leupandiazide diuretics, and dioxide can also increase the hyperglycemic effects. So how do you classify these drugs? So these drugs can be classified into around, I'll say 6, even though we are seeing 4 over here. So into insulin secretagogue, non-insulin secretagogue, insulin sensitizers. We have a more specific dipeptidyl peptidase, and we should also be having the glucagon-like peptide 1 receptor. So let's write it over here. Glucagon like peptide 1 receptor, and also sodium glucose co-transporters inhibitors. So for the sulfonylurea, we agreed that this can be divided into 2, where we are having the first generation and the second generation. So the first generation, chlorpropamide, tolbutamide; second generation, glibenclamide, glipizide, glycoside, glimepiride. We also have the non-sulfonylurea derivatives. An example is the meglitinide, where you can have repaglidine and the nategladine. We have the non-insulin secretagogue, such as the alpha-glucosidase inhibitors. This includes the acarbose, voglibose, and also the miglitol can also be in this group. We are having the insulin sensitizers, including the bioguanides, not the mide. Replace this with N. This includes metformin and fenformin. We are also having the dalazolidinediones, including the pioglitazone, the rosiglitazone, and of course the dipeptidyl peptidase inhibitors. So example of such are the sitagliptin and the vidagliptin. So let's go straight into the sulfonylureas. So we've suggested that we have 2 classes of sulfonylureas. So we have the first generation and the second generation. So the classification is mostly based in terms of the time with which the time of discovery for this drug. So you say that the first generation were the first to be discovered in this group, followed by the second generation. So it was necessary for us to for the pharmacological group to discover the second generation, or maybe to develop the second generation. This is because they normally have stay in your body for a shorter time than the first generations. So that means the second generation has a reduced risk of hypoglycemia. So how do the sulfonylurea act? So the sulfonylurea are likely to act mainly by augmenting the insulin secretion from the pancreas. It is effective for some residual pancreatic beta cells activity. So this needs to be present. So if you are dealing with a patient who do not have, maybe their pancreas is totally destroyed, where they do not have the remaining beta cells, these drugs will not work, because this drug should be encouraging the remaining beta cells to produce more and more insulin. So if you do not have beta cells, this drug will not work. How is it likely to achieve this? So this is achieved by a reduction in the serum of glucagon. So remember, the glucagon had an antagonistic effect to the beta cell. It was able to suppress the antagonize the actions of the insulin not really having a direct effect on the cell, but somehow reduce their action. Sulfonylurea is likely to aid in the closure of the potassium channels. So remember, in the process of secretion, the chemical pathway. So what happens if the potassium channels are closed? It means that the depolarization will even be much obvious, and will open the calcium channels. The calcium will be a cofactor in the activation of the protein kinases, allowing the exocytosis to take place. So the sulfonylurea are very important in closing the potassium channels in the extra pancreatic tissues. Sulfonylureas are well absorbed orally and are 90% of it are bound to the plasma protein. So it means that they are likely to be there in the system for a long time. So we can classify it to first and second generation. So example of the first generation sulfonylurea: chlorpropamide, where brand name have the diabinase or diabonis, dolbutamine, and also tolazamide. Second generation, glibenclamide, an example, dionyl euglucone or the no-gluc. You have the glipizide, glimepridine, gliclazide, and glipridone, all of these existing in different brand names that you can get in the pharmacy. Now on to the specific attribute of the drug. So let's start with the chlorpropamide. Even though we'll discourage ourselves from using this, considering that this maybe is a first generation drug where it has a high tendency of causing hypoglycemia. So we'll be very cautious while using this. So mechanism of action are likely, of course, to respect the mother group, or which is the sulfonylurea. The chlorpropamide directly stimulates the release of insulin from the functioning beta cells. So the beta cells need to be functioning by inhibiting the ATP potassium channels on the beta cells membrane, and of course the K efflux or the potassium efflux. This will cause depolarization, calcium influx, the calcium calmodulin binding. The kinase will be activated in the process, and this will be favoring insulin to be released from the secretory granules via exocytosis. So these are indicated in for type 2 diabetes mellitus or uncomplicated and ketotic diabetic mellitus. So this oral hypoglycemic, remember, they are mostly for the type 2, where you are suggesting that insulin are there and maybe not acting as adequately, or we are still having the beta cells that still have the capability of producing the insulin. In terms of drug interactions, so just similarly with what we discussed, so just an highlight: drug that enhances the action of the sulfonylureas are phenylbutazone salicylate, the PAS, and the sulfonamides. It can do that by displacing the sulfonylureas from the protein binding, so that increases the amount of sulfonylureas that are free to act. We have the phenylbutazone again, cimetizine, warfarin, chloramphenicol, and of course alcohol intoxication acutely, and sulfonamide. So this might do this by inhibiting the metabolism and excretion of the drug, so somehow potentiating the effect of the chlorpropamide. We can also have salicylate, propranolol, and again alcohol synergize with and prolong the pharmacodynamic actions of the drugs. So this means that to an extent, these drugs can also be able to cause hypoglycemia. So we have drugs that might reduce the metabolism. So this include the reduce their function by inducing the metabolism. This include the phenobarbital, phenytoin, rifampicin, and chronic alcoholism. So under these circumstances, the metabolic enzyme are likely to be released at a greater with much greater quantity. So we also have corticosteroid, thiazide, furosemide, and oral contraceptive that are likely to give us an opposite action or suppress the insulin release so that we end up with hyperglycemia. So while using the clopropamide, you need to take some precautions, and that is regularly monitoring of your RBS. If you are elderly, the chances of getting the hypoglycemia is highly likely because of increased sensitivity to the drug. Also those in the bicarbonate therapy, and also Addison's disease and obesity. Contraindication will be the DKA, juvenile diabetic mellitus, mostly likely to be type 1. Severe diabetes mellitus, where maybe the sugar is extremely high. You might require a drug that is likely to control the sugar with much speed. Oral hypoglycemic agents are not example of such, so insulin will be preferred in that state. So unstable DM, Raynaud's disease, pregnancy, gangrene, severe trauma, fever, severe renal, hepatic, thyroidal function impairment, and also severe inflammation are some of the circumstances under which these drugs are contraindicated. Side effect, of course, you won't forget hypoglycemia. You can also have some GIT disturbance, jaundice, skin rashes, hypersensitivity to some individual, headache, dizziness, some blood dyscrasia, edema, photosensitivity, hyponatremia, paresthesia can also be there. Dose is available in 250 and 100 milligram tablets, where you can take around 250 to 500 milligrams once a day after breakfast for adults. And elderly, for the elderly, you'll need to reduce the dose to up to around 100 to 125 milligrams. So let this be milligrams, again once a day. This is because we say that these individuals are likely to have some hypoglycemic effect, but it is better if you don't use it and use other agents, preferably the second generation. Some of the common name of the clopropamide are Diabenis, Diabonis, and also Diabecum, Diabetex, and a lot of them also existing in the industry. Another drug, glibenclamide, even though this is a second generation, famously known as the no-gluc. So they have similar features just with the clopropamide. It's only that they are likely to be there in the system for a shorter duration, having that these are now the second generation sulfonylurea. So normally available in tablets, a dose ranging from around 5 milligrams, and we can also have the 10 milligrams. How do you give? It can be given 5 milligrams once a day or twice before a meal. If there's need for you to increase the drug, you will rather be increasing it by 2.5 milligrams until the glucose is controlled. So rather than jumping from 2.5 to 7 or from 5 to 10, you'll rather increase it to 2.5 with the 2.5 to your desired dose. So whereby the maximum dosage an individual should be taking should be 15. So if there is a need for an individual to take more than 15, consider using another agent. So common names are no-gluc, Dionil, euglucon, and gliben. So it can also exist in combination with metformin, with the various mostly 5 milligram compound with the 500 milligrams of metformin. So these are the various brand name, but famously we have the glucomate N, the N part representing the no-gluc, that is the glibenclamide. We also have the glimepiride, a brand name Amiryl. Of course, it's a sulfonylurea sharing the same attribute, only that this is likely to be in the system for a shorter duration compared to the first generation sulfonylurea. The side effects are GIT disturbance, the blood dyscrasia, hypoglycemia, jaundice, skin rashes, hypersensitivity reactions, headache, dizziness, edema, hyponatremia. So the dose we have tablets of 1 milligrams, 2 milligrams, 4 milligrams, whereby you can have initial dose of 1 milligrams once a day before first meal. You can increase by 1 milligram at an interval of 1 to 2 weeks to a maximum dose of 4. So you don't just start at the maximum dose. So it is good to start at a lower dose and you increase by around 1 milligram every week or after every 2 weeks. This will help to minimize the effect of hypoglycemia. Also, in the second generations, we have the glycoside and the glyquidone. So glycoside can have it their micron given between 40 to 80 milligrams, can also have the 60 formulation. So a maximum single dose of 160 milligram, maximum dose of 320 milligram. So we have the glyquidone available in 30 milligram tablets, can also have the 15, where the maximum dose can be given between at most 180 milligrams a day, where at a go the maximum dose that you can take at a go should be 60 milligrams. So at most that will mean 60 milligrams TDS. So also within the insulin secretagogue, we have the meglitinide, otherwise referred to as the non-sulfonylurea insulin secretagogue. So as the name suggests for the insulin secretagogue, it means that they should also be able to encourage the secretion of insulin by the remaining beta cells. So what is their mode of action? Meglitinin analogs, these are recently developed quick and short-acting insulin releases. They do this by closing the ATP-dependent potassium channel, and if this happens, of course, the depolarization is likely to take place, and the influx of calcium is likely to increase. So, example of this, we only have two in our notes: repaglidine and nateglidine. So, indication. So, these are indicated for type 2 diabetes. The good thing is that this can be used as a monotherapy, unlike with the sulfonylurea. With the sulfonylurea, you'll prefer another compound, so maybe say a biguanide such as metformin, and maybe if it is not working adequately, you add a sulfonylurea as a booster. So repaglidine can be used as a monotherapy, or it can be used in combination therapy with drugs such as metformin. Chemically, this is a carbamoyl methyl benzoic acid derivative that acts by stimulating the release of insulin from the pancreas. So let's just remember, it will close the ATP-dependent potassium channels, and the rest of the story it's known to us. You need to be cautious. It may cause the resumption of ovulation in the premenopausal and ovulatory patient. These are maybe those with those who are not ovulating, not because of the age, but maybe because of some circumstances such as let's talk of polycystic or cystic cystic ovary. So this might cause the resumption. Contraindication, these are contraindicated in breastfeeding. You don't want to use this in type 1 diabetes. You don't want to use this in DKA and in hepatic disorders. So remember, most of the oral hypoglycemic agents are not preferred in the DKA because they have an increased risk of getting giving us the lactic acidosis. So that will be worsening our acidotic state in the DKA. The side effects that you are likely to get with the nateglidine, peripheral edema, URTIs, back pains, headache, anemia. The dose, patient previously untreated with hypoglycemic agent whose HbA1c is less than 8, you can give 0.5 milligram orally. Patient previously treated with oral hypoglycemic agent whose HbA1c is more than 8, give 1 to 2 milligrams orally. At least if they've been treated, you'll not be too much worried with the hypoglycemic factor, even though it's a possibility though. This drug is available in tablets ranging from 0.5 to 2 milligrams, where you can have 0.5 milligrams, 1 milligram, and 2 milligram. Some of the available name in the market are Novonorm and Premid. We might also have some others. So let's talk of the non-insulin secretagogue. An example is the alpha glucosidase inhibitor. So just as a text, monosaccharides such as glucose and fructose can be transported out of the intestinal lumen into the blood. But complex starches such as oligosaccharides and disaccharides needs to be broken down into individual monosaccharides before they are absorbed in through the duodenum and the duodenum. So this is just with the normal digestion process. We require monosaccharides for easy absorption. So example of such enzyme that should be able to break down the oligosaccharides and disaccharides, one of them are alpha glucosidase. So we are having alpha glucosidase acting alongside other enzymes such as alpha amylase. So if you have a drug that antagonizes the alpha glucosidase, it means that will reduce the amount of monosaccharides that are there within the GIT lumen. And therefore, what does this mean? Will reduce the absorption. And if the absorption reduces, it means that we'll be able to reduce or maybe limit the amount of glucose that is available in the bloodstream, within the blood. So example of these drugs, as we suggested, are acobos, voglobos, and also miglitol. So acobos, a brand name by the name Glucobay, is a competitive inhibitor of an alpha glucosidase and reduces the postprandial digestion, so you'll be having more of the disaccharides and oligosaccharides. Of course, it is obvious that the side effect for this will be flatulence, because if you do not break down these disaccharides, oligosaccharides, and they get into the large intestine, this will be subjected to the bacterial fermentation process, where the bacteria will digest this and it will produce a lot of gas. This will present with flatulence. So example of such drugs, to be more specific, acobos. The mechanism of action, of course, this acts by inhibiting the intestinal alpha glucosidases, and for this reason delays and decrease the digestion and absorption of starch and sucrose. This is indicated for diabetes mellitus, which is inadequately controlled by diet or diet with other oral hypoglycemic agents. So as you get it, it might not be our primary oral anti-diabetic agents. So other agents need to have failed, so they should just come to try at least to assist. So what are the precautions? You need to monitor the serum hepatic transaminases in patients receiving a dose of 200 milligrams a day, at least for the first 6 months. This may enhance the hypoglycemic effects of insulin or sulfonylurea, so you be cautious, and that's why it's becoming we are using it as a secondary drug. You will need to treat the hypoglycemic spells with glucose and not sucrose. So this is what we normally get with the hypoglycemia. Contraindication below 18. So find out maybe why below 18. But of course, the people below 18 are still growing. Contraindicated in pregnancy. States that the deterioration due to gastrointestinal formation might increase maybe a rupture in instances where there is intestinal ulcers and hernia. So you might not want to use it in instances where you want to discourage gas formation. Also avoided in breastfeeding: severe renal impairment, severe hepatic impairment, inflammatory bowel disease, intestinal obstruction, colon ulceration, and those who have had recent history of abdominal surgery. So drug interaction: it's likely to enhance the effect of the cholestyramine. It is likely to enhance the gastrointestinal side effects of the neomycin. It is likely to potentiate insulin and sulfonylurea. It's likely to reduce the effects or the effect of the digestive enzyme. Side effects are flatulence, increased bowel sounds, abdominal pain, hypersensitivity reaction to some individual, jaundice, and hepatitis can also be seen. The dose is normally 25 milligrams, 3 times a day. Start at the start of each meal, main meal that is. Adjust the dose 4 to 8 weeks intervals, up to around 50 milligrams, and then 100 milligrams 3 times a day. So that should be a presumed maximum. So it's available in 50 and 100 milligrams tablets. So the brand name, Glucobay. Other group of oral antidiabetic drugs are bioguanides. So by far the most common in this are normally metformin. So maybe what you need to notice with this, these are normally considered a euglycemic agent. So this means that if the sugar level is high, so it's only able to lower it up to the optimum level so that the person become euglycemic. In that when you use these drugs, there is a reduced chance of getting into the hypoglycemic level. So unless the dosage of this biguanide or metformin is increased mostly to a toxic level, so unless you are dealing with an overdose, that's when you are likely to get the hypoglycemia. So you get hypoglycemia in an individual who is just taking the metformin. So just think of the overdose and maybe explore why these people are overdosing themselves. Is it as a because of not knowing, or maybe they are having other intentions? So example of biguanides are metformin and fenformin. So what do these drugs do? So this can otherwise be referred to as the insulin sensitizers, both biguanides and the lizolidinones. Metformin normally directly stimulates the glycolysis in the tissues, which increases the glucose removal from the blood. So this will suggest that a tissue, once it has absorbed maybe a glucose, it needs to utilize it. One of the utilization of the glucose is to utilize glucose to give us some energy. So that is glycolysis. So if glucose is utilized, it means that the concentration difference within the cell is likely to be low, and there will be a great need for the cell to even absorb more and more glucose from the bloodstream into the cell. So that's how the metformin is acting. It's increasing the glycolysis, and while increasing the glycolysis, utilizing the glucose, it is creating a great need for the cell to get more and more glucose, and therefore removing the glucose from the peripheral. So this is a simple explanation why you can say that this drug are insulin sensitizers. This is because they also increase the demand for glucose within the cell, something which insulin normally does in terms of allowing the cells to incorporate the insulin. So while insulin is opening the channel, the drug is increasing, for lack of word, let's talk of thirst for glucose within the cell. So this drug is also likely to reduce the hepatic and renal gluconeogenesis. So we'll also be able to go slow on the production of glucose. A similar role with the insulin. So this is somehow potentiating the effect of insulin, or again, more conveniently, sensitizing the role of the insulin. It also slows the glucose absorption from the GIT and increase the conversion of glucose to lactate by enterocyte. So this is again utilization of the glucose. So remember, for you to get lactate, it's normally it could also can also be through the glycolysis process, whereby after glycolysis of the glucose, likely to get a lot of the pyruvic acid. If you are having a lot of pyruvic acid, this will be converted into lactate. So having some form of lactate. If lactate are released into the bloodstream, so this will give us the very much unwanted lactic acidosis. A good example where you will not want to use metformin in those who are having DKA. So these are also able to reduce the plasma glucagon level, and in so doing, you'll be reducing the amount of glucose that is there in the bloodstream. So what are some of the indications? Apart from diabetes mellitus, it will be much preferred to use metformin if somebody is having type 2 diabetes mellitus and they are also obese. So overweight patient and type 2 diabetes, when dieting and sulfonylureas have failed to control the diabetes. So precautions, dehydration, infections, trauma, you need to discontinue the drug 2 to 3 days before the surgery. So remember what we had suggested with most or all the oral hypoglycemic agents. Drug interaction, increased effects such as with cimetidine, antidepressant, we have beta blockers, where cimetidine reduces the clearance and anticoagulants act as a possible adjuvant. So these drugs is contraindicated in DKA, in diabetic coma, cardiac failure, pancreatitis, trauma, severe infection, pregnancy and lactation, dehydration, hepatic and renal impairment. The side effect mostly for this drug is lactic acidosis. And remember, we suggested that this drug is not likely to cause hypoglycemia unless the person has consumed a magnitude amount in terms of metformin. So this drug can be available in various dosage, tablets most of the time, 500 milligram, 850, and you can also have the 1 gram or the 1000 milligram. So this can be taken, the maximum dose 3 grams per day, but I'll recommend 2 grams. So if the patient is operating at 2 grams BD or twice, rather than increasing that dose to 3 grams, just consider adding another molecule. So some of the common name in the market are metformin, glucophage, glucomet, ranforage, trapophage, and many others that you'll find. We also have another form of insulin sensitizers. So these are referred to as the zolidinodiones or the glitazones. So where example should be something like the proglitazones or the rosiglitazones are what we are referring to, the glitazones. The zolidinodiones acts to increase the insulin resistance, to decrease insulin resistance, that is, are effective only in the presence of insulin. They bind to the receptors, the peroxisomes, proliferators in the adipose tissues, skeletal muscles, liver, activating the transcription of insulin responsive genes that controls the glucose and lipid metabolism. Indications. These are indicated in the type 2 diabetes mellitus. You should be cautious in those who are breastfeeding, and it might also cause the resumption of ovulation, similarly to what we saw with one of the meglitinoxide. That was the nateglidine. Contraindication: breastfeeding, type 1 diabetes, DKA, and hepatic disorder. So contraindication for this oral hypoglycemic are likely to be just similar. So side effects for the this group of drugs: they can cause the back pain, peripheral edema, anemia, URTI, some tooth disorders. We have the two type of drugs that we'll be exploring as the pioglitazone and the rosiglitazone. Pioglitazone normally available between 15 to 30 milligrams, where you can be given to up to 45 milligrams a day. Rosiglitazone between 4 to 8 milligrams, either once or twice a day. So pioglitazone, what are the indications? Normally indicated for type 2 diabetes mellitus. This drug can also be used as a monotherapy or in combination with other group of drugs such as the sulfonylurea, the biguanides where you have metformin, or sometimes can also be used by the together with the insulin, also in the diabetic type 2. So we've suggested that available in tablets, you can have the 15 or the 30 milligrams, where you can oscillate between 15 to 30 milligrams, maximum 45 milligrams a day. So this is not you can take it even it doesn't need to be before the meals. Example of such drugs are glustein, glitas, and pioglutes. We have the rosiglitazone, sharing similar attributes just like the pioglitazone. Precaution: breastfeeding, diabetic type 1, DKA, hepatic disorders. Side effects, so these are precautions and contraindications. Side effects: peripheral edema, URTI, back pain, headache, anemia. Dose, so this can also be used as a monotherapy, available in 4 milligrams, where you can give it between 4 to 8 milligrams with BD, and again this again is without regard to meals. It can also exist, or it can be given in combination with metformin, mostly the 500 milligrams. So that is with the general anti-diabetic drugs. So we'll have an extension with the others in terms of activity, but as we continue maybe into the general attributes or maybe how you can generally manage the diabetes mellitus. So far we've been suggesting the oral hypoglycemic agent and the insulin, but we know that weight, diet, and of course exercise are very important. So how are you able to approach maybe somebody with diabetes mellitus? So diabetes mellitus, majorly it can be type 1 or it can be type 2. So number one, you'll need to control the diet, where you'll want to restrict their carbohydrates, because once digested they can increase the availability of glucose in the bloodstream. You'll want to reduce protein in patients with the neuropathy. You'll want to control the weight of this patient. If these people are obese, advise them to reduce the weight, and of course this is by exercise and diet. If these people are underweight, encourage them to gain weight. So this is more so can be seen in those who are having diabetic mellitus type 1. Selection therapy. So initially, of course, you want to use diet alone. If diet is effective, well and good. If diet is not effective, assuming you are dealing with type 2, you'll want to incorporate an oral agent. And if an oral agent is not as effective, think of another oral agent. Think of the best combination. This is because even though it might be needed, most people are hesitant in terms of administering or maybe taking the insulin. So nobody prefers to be having a long life injection. So you'll rather choose the best available oral anti-glycemic, oral hypoglycemic agent for them. But there are some circumstances, such as in DKA or in some other complication, where of course the oral hypoglycemic agent will not work. You'll just give the insulin. So diet and insulin, this could be much appropriate, especially for the type 1 diabetes. So if somebody is a type 1 diabetic, diet sometimes can be able to control. If not as adequate, you'll need to introduce them to insulin. So with the internal med, I'll want you to look into the maybe specific algorithm of insulin administration. So that is answering the simple question on how do we start to give the dosage, how do you increase, and of course how do you reduce the dosage should it be required. For the type 1 diabetes, if you want to achieve adequate control rather than the oral agent, so these are people who you might prescribe maybe soluble or the insoluble insulin. And of course, this is likely to depend on many other factors. For the type 2 people, you give them oral agents, that is on top of diet, of course. And if there is a secondary failure of this oral agent, you can give insulin. There are also some factors that you need to be considering while managing such people. This is you need to control these factors. Remember, while we are speaking of or maybe talking about the insulin resistance. So the resistance can also apply to the oral hypoglycemic agent. So these are things such as the intercurrent infections, menstruations, oral contraceptives, pregnancy, and things like premature labor. So where the person will be in a position or in a stress situation, and in the context of surgery. So these are some of the things that might affect the diabetic control, either with the drugs or with the insulin. So you need to keep that at the back of your mind. And you should also be aware of how you should be able to manage one of the commonest complications of the DKA, the guiding principles that should be used while managing the diabetic ketoacidosis. So these are the patients you want to admit and monitor their blood pressure, their respiratory rate, their pulse rate, and you should also be checking their mental status every 1 to 4 hours, considering that confusion could also be part and parcel of the symptomatic presentation. You'll also want to do investigations such as uremogram, blood sugars, urea, electrolytes such as the potassium, sodium, magnesium, phosphate, bicarbonate. Because dehydration is also an issue, you'll also want to monitor their input and output of fluid. You can have the fluid replacement therapy, where you can give the IV fluids, so preferably the normal saline, according to their dehydration status. So averagely that should be around 6 liters. So how do you want to give this fluid, or rather the normal saline? So within the first 1 hour, you can give maybe within the first 30 minutes, you can give around 1 liter of normal saline rapidly, and then after 1 hour, and then after an hour you give 1 liter, then 1 liter in 2 hours, and then 1 liter in 4 hours and 1 liter in 6 hours, so that at the end of the around 8 hours, these people will have received around 6 liters. So in the management of DKA, you also want to do fluid. So this is fluid restoration. So this is normally by normal saline, and your schedule should be like this. So while administering fluids and possibly insulin, they might reach a time when the sugar might fall below 13. So if it falls below 13, you'll need to give a dextrose 5%. This is because you want to be cautious so that the patient does not develop hypoglycemia. So you want just to give it, you want to lower the sugar just slowly. So on top of fluid therapy, we also have insulin, which is definitely needed. So this is the regimen. Even though the standard should be around, you can give around, so let's just write here on top. You can give around 0.1 international unit of insulin, maybe per hour per kg. So if let's say if you are supposed to monitor this patient for, let's say, 8 hours, and this patient is maybe 70 kg, so that means that you'll give them 70 times 0.1, that is 7. So this is around 56 international unit. So this you will place it in 500 normal saline, but I normally prefer maybe you do it after you prepare your insulin for around 4 hours. So rather than the 8, I'll give the 4. So this will be 28 international unit. I give it for around 4 hours. So this I'll put it for 500 in 500 normal saline. And if there is need for you to continue up to 8 hours, another 4 hours. So this means by 4 hours, your 500 normal saline will be over. You give another 500 and place 28. So you will calibrate your flow to make sure that the flow continues to around 4 hours. So that means your patient should be having 2 lines. So one receiving the fluid and the other one receiving the insulin, which is going rather dropping slowly at a rate of where it should be able to flow to up to 4 hours or maybe 8 hours. So I think it is good to break it down to 4 hours so that you don't put 56 international unit in 500 ns. Yeah, even though it can last 8 hours, but this I think is more efficient, because remember, these drugs need to be stored within the fridge. So 56, that will mean that we will be talking of 2 to 6 to 8 hours of our drug off the fridge. So when you give it at 4, that means you'll be minimizing the amount of time that our drug will be off the fridge, and it's likely to be much efficient than the 8, even though theoretically they are just the same thing. Of course, the insulin that you will prefer to use is the short acting or maybe the rapid acting, because remember, the DKA, you want to control your sugar as soon as possible. So I'll rather do the short acting because it will act reasonably fast and not as too fast. So the risk of the hypo again will just be on the low. So on top of fluid insulin therapy, you'll also need to supplement this individual with potassium. And for you to do that, you'll need to monitor their potassium level. If their potassium level is more than 6, They don't require a potassium supplement unless you are in a position where you are not able to monitor their potassium level. If the level is between 4 to 5.6, you need to supplement. This is the range or the rate with which you can give in correspondence to the amount of potassium that is there in the bloodstream. So remember, potassium theoretically it should be a must, because remember, in this state you are giving a lot of insulin. One of the things that insulin normally do is they normally encourage the absorption of potassium from the extracellular or maybe from the blood into the cell. So if you give insulin, a lot of potassium are likely to get into the cells. So it is fairer if you give the potassium to prevent the hypokalemia that it is anticipated in the context of DKA or during the insulin therapy. So just remember that. Because the patient is also acidic, depending on their level, you also need to supplement or maybe give bicarbonate. And you'll also need to give antibiotic, because one of the reasons why people might get the DKA, one of the leading causes are infections. So give the appropriate antibiotic as needed to the patient. So as a continuation, I'll want you maybe in your group to read on the dipeptidyl peptidase inhibitors and the sodium glucose cotransport inhibitors, also known as the